Starting with our today's clinical meeting. Our first lecture is Breakthrough Innovation in Pregnancy Care, Novel Folate and Choline Duo by Dr. Ketki Joshi Madam. Dr. Ketki Joshi Ma'am, she is a consultant at Ramakrishna Hospital, Vinayak Hospital. She has more than 12 years of experience in obstetric practice. We welcome you, ma'am, and over to you.
A hearty good evening to all. Today I am going to speak on breakthrough innovation in pregnancy care, a novel folate and choline combination or duo to improve pregnancy outcome. As we all know, today is an era of smarter kids with potentials for better. Everybody wants to have kids like Elon Musk and Sachin Tendulkar and Kohli. And we all know that folic acid plays a critical role during pregnancy, especially in early stages of organogenesis. Now, maternal consumption of folic acid, that is folate supplementation, is well accepted pregnancy management strategy, but still there is a lot of scope to do more and better. Now, we are aware that during the time of organogenesis, that is day 17 to 28 post-conception, is crucial for neural tube closure. Deficiency during this period is linked to neural tube defects, cognitive and behavioral disorders, which occur later in life. Now, before we go on to today's topic, let us just see what is folic acid metabolism. Now, the folic acid, that is synthetic form which we have been prescribing all these days, it is a synthetic form which needs to be converted into an active form, that is folate. Now, this folic acid is converted to tetrahydrofolate by enzyme dihydrofolate reductase. Now, this is further converted to 5,10-methylene tetrahydrofolate, which is then converted to the active form, that is 5-methyl tetrahydrofolate. Now, this conversion is done by methylene tetrahydrofolate reductase enzyme. Now, this enzyme plays a very important role, and sometimes in few patients we do get mutation or deficiency of this enzyme, and that is why the active folate form is less in circulation. Now, what is quadrifolic? This is the 4th generation folate, that is active 5-methyl tetrahydrofolate. Now, it is a bioavailable form of folate which does not need any conversion. Especially important in, as I just mentioned, that this methyl tetrahydrofolate reductase gene mutation. So, in these patients, it is very much required because the inactive form cannot get activated if this gene mutation is present. Now, all folate forms cannot transfer a methyl group. Only certain folate forms can transfer the methyl group to target sites. Now, this 5,10-methylene tetrahydrofolate and 10-formyl tetrahydrofolate can directly transfer a methyl group to target tissues. Both these are the active folate forms. Now, other forms available in plasma, they need transformation to these active forms of folate. Most supplemented folates are in inactive form, as I said previously, dihydro and trihydro, or in storage form. So, most supplemented folate forms need to be converted to active folate in presence of covitamins. Now, depending on the dosage and duration, inactive storage folate is detected in serum, which gets activated in due course of time. Now, this depends on the dose of folate intake, duration of folate metabolism, demand of active form of methyl transfer, and most important, the availability of this reductase enzyme. Sufficiency of methyl groups in the methyl pool. Now, the advantages of this active 5-methyl tetrahydrofolate over folic acid, we have already seen that conversion is not required for the active form, as well as the enzyme reductase is not required in case of active form, whereas folic acid needs to be converted. Bioavailability is highest in case of quadrifolic. Now, clinical benefits of this quadrifolic, it reduces the risk of neural tube defects, preeclampsia, low birth weight, and it supports DNA synthesis and repair, as well as homocysteine regulation, which we'll come to it further. Now, folate provides active methyl group, which is needed for DNA methylation, which is important for embryonic development. One more significance of active form of folate is that folate converts homocysteine into methionine, which is an essential amino acid. Thus, it reduces the excess of homocysteine level in the body. As we all are aware that hyperhomocysteinemia can cause many ill effects like recurrent fetal loss, preeclampsia, gestational diabetes, anemia, mainly megaloblastic, miscarriages, etc. Now we move on to a second important thing is choline. Now this is an essential nutrient which is often under-consumed in pregnancy. We are not much aware of the importance of choline in our diet. Now this is found in eggs, meat, fish, and soybean. Now each choline molecule can donate 3 methyl groups to methyl pool. Now role of choline in early pregnancy is, it again helps in brain development, cell membrane integrity, neurotransmitter synthesis, and it aids in neural tube closure, which is again synergistic to folate. Now the recommended dose for choline is 450 milligram per day, out of which only 10% of pregnant women meet this requirement. So supplementation of choline is advised in diet as well as supplementation if diet is insufficient. Now both this quadrifolic plus choline, they play a synergistic role. Both impact methylation pathways critical for DNA expression. Combined deficiency can impair neural tube development, but together they support epigenetic regulation and optimal fetal growth. Clinical evidence, many studies have shown improved cognitive outcome in offspring with both choline as well as folate intake. Reduced homocysteine levels with quadrifolic supplementation, higher birth weight, and better Apgar score. So the recommended dose of quadrifolic is 400 to 800 microgram, whereas choline it is 350 to 450. Second thing, what is recommended is, if possible, the methyl tetrahydrofolate reductase status can be assessed. And third is dietary sources which have choline should be included. Of all folates, quadrifolic during pregnancy has been shown to produce least unmetabolized folic acid. Now this again is important because the unmetabolized folic acid in the circulation also has got ill effects. So the active form does not produce any unmetabolized folic acid as compared to the inactive folic acid. Now ACOG also recommends a dose of 450 milligram of choline supplementation across all trimesters of pregnancy. Finally, I would say that first trimester is a critical for brain and neural development. Quadrifolic is superior to folic acid and it should be recommended. Choline is often overlooked, but it is essential. And dual supplementation of folate as well as choline offers synergistic benefits during development. Thank you.
So much, ma'am, for very insightful presentation. Now I request Dr. Milind Shah, sir, for the next talk on maternal immunization. Dr. Milind Shah, sir, he's a renowned gynecologist, more than 30 years of experience in the gynecological practice. We know him very well. We welcome you, sir. Over to you.
Thank you very much, Snehal, for those kind words. At the onset, I must say big thanks to Solapur Vijay Society. Yes, Sujata, Ketki, Lata, Snehal, for this good opportunity, because I understand, though it is a very common problem, we saw that change. And that change made us more prosperous in our practice. Because I remember when I started my early days of practice, when my teacher is very much in front of me, used to give 3 tetanus dosages. And eventually we learned that yes, the 2 are adequate. rather 3 causes, more chances of hyperbilirubinemia in one of the study where it came. And then I thought, yes, we definitely should share something with our colleagues as well. And thanks to the GSK group for this wonderful opportunity. But friends, when it comes to the viruses, I always remember the COVID pandemic first wave, because probably you may not be knowing, when the pandemic came, naturally we were worried about our pregnant women. And the first lady who came to us with COVID positive status near term, who was a doctor, and she said, now what to do? Because that time the government hospitals were bombarded. There was a lot of crowd. Many of us were confused because it was just 2-3 months experience from whatever we learned from the China. No literature available. What to be given, what not to be given, how to manage, and at the end, always worried about getting that infection ourselves. And that's why everyone was very much scared what to do. That time I was 58 years old, so everyone said you are not supposed to even enter the COVID ward when the first pandemic came. But somehow I felt that there is something need to be done, and I put these gears on me, and I said I must do something for this. And to my surprise, the entire team came to my rescue. So I'm thankful to the Yashodhara Multi-Speciality Hospital, who decided to give me a lot of changes in their OT, decided to give me this team, and the team members also agreed to work for that. 2 OBGYNs, 2 anesthesiologists, 2 nurses, 2 OT assistants, 2 runner nurses, which I learnt in those 2 months, who used to just run from the OT in outside, bringing the personnel inside, like pediatrician used to just come to see the baby and go back immediately outside, because we were worried. And of course, 2 attendants. I always salute them because we were actually doctors. We understood that we can do something for it, but the attendants definitely have more fear because they are not that empowered as we all are. But they all agreed, and to my surprise, after making all those changes, we removed that positive pressure ventilation from the OT. We put one window actually in the OT, and we could deliver 24 COVID positive women. And to my surprise, none of our members got the COVID positive status. None of our babies got the COVID positive status. It's because the protective gear were very well used, and we gave a good emphasis on the mother part as well to tell them how it could be. In fact, it was a very rush sort of thing coming here, because yesterday only I came from Mongolia, and now I'm traveling tomorrow for Chennai and day after tomorrow to Delhi for this oration. But I promised Sujata, and Sujata said it's society is definitely advantage. So definitely I said I will come for 2 days. I will definitely deliver this lecture, and I will rush for the Siddheshwar Express to catch my flight at 5 o'clock for Chennai, because this is again an important part. You all know that you will all have to support me a lot for my candidature of the FOXI president. So coming to the topic very quickly, yes, first before that I must put these disclaimers which have been put by GSK as well, because we all know that we keep on learning. Whatever we say today may not be absolutely correct tomorrow, and whatever we did yesterday may not be absolutely correct today. So that's why the medical science is all about, and what we'll have to do that we'll have to select actually all those whatever experiences we have, and we'll have to accordingly take our own decisions as a clinician. So even whenever new molecule comes, someone asks me to deliver a talk, what I do, I take first monogram, and I read that monogram. I find it, I use it a couple of months, even when the new molecules like Elatab came and all those drugs. I said, I will use it for my endometriosis patient, then I will give a talk, because that will be a real practical experience as well. So this is a disclaimer from my side as well, because I know that everyone may be having different opinions, and we respect the each and everyone opinion of all those 148 members of our society as well, because whatever information we get, we try to discuss, we try to understand. And when it comes to the maternal immunization, it's definitely a very important aspect. You know, there are many homeopaths who practice in the city, and they say, we don't believe in immunization. We don't give any vaccines. I know some of the homeopaths, they don't even give a single vaccine to their own children as well. Where I work actually as a HOD in the Department of OBGYN in the Gandhinatha College, I know some professors there, they say that they don't believe in immunization. But it is definitely has its own role as well, because it has a long history when it comes to the mother and various infections are concerned. Especially the infections which are very much, very bad, we can say all about, like tetanus toxoid. In my practice or in my postgraduate training, we never saw a case of tetanus. But I know that there are many senior people here, they must have seen actually these cases. And there are a lot of vaccines which got introduced one after other, and then we actually started using it very effectively because we wanted to care about our patients as well. Quite often nurses teach us a lot of things. And I remember one of the nurses who came for ANS registration, when we said that we are going to give the vaccine in the 4th month, she said, but suppose I get an abortion and it gets infected, can I get a chance to getting the tetanus infection? So why not given to be early? And then I realized that yes, slowly government guidelines are also changing. The first visit we always prefer to give at first trimester because we don't know what exactly is going to happen when it comes to the period of organogenesis as well. So several non-live vaccines have been found to be generally well tolerated and immunogenic in pregnant women and their neonates, and we need to utilize them whatever actually we know about the immunological response of the baby as well as the mother as well when it comes to the pregnancy, because this is a compromised state where we know that something foreign body is coming in the body of that woman and probably that may be rejected by other immunological system. That's why we know about it as a cause in the repeated pregnancy loss as well. So this immune system modification is one of the cause where the infection also can take advantage of it, and non-immune physiological changes may impair the pathogen clearance also, because we know that there is another change which we call adaptation of the pregnancy as well. Same way the baby, we start the vaccination, especially for this all major viruses which affect the respiratory system in the month of 1.5 month of that baby's life. So though the baby is protected for hepatitis B, the zero polio, we are always worried about whether baby will get something like influenza or any other viral infection. So this early infancy period need to be again protected, and that is the advantage which the science gave us of giving protection by the time the immune system develops in that particular baby, and that maturity may not cause some bad problems actually. And there are many studies which I am going to show you very quickly. And it is very true that suppose we give any vaccination at very early stage, there may be some untoward effects as well, so we'll have to work on that. And the maternal immunity, because finally mother always takes care of her child, need to be properly passed on. There is always increased susceptibility to the severity of certain diseases during pregnancy, as well as the first few weeks of life, which are important. In maternal immunization, antibodies are transferred across the placenta, providing passive immunity to the newborn child. And you can see this particular path as the pregnancy advances. This actually passage goes on increasing, and that gives a sort of passive immunity which we must utilize, and that's why we started thinking of using the Tdap after 28 weeks, because we wanted to pass on that immunity to the baby as well. So vaccination during pregnancy is recommended by the global groups, the national expert health authorities, including the FOXI, because FOXI always prepares some certain GCPR guidelines. Those are basically to understand the Indian scenario, because all said and done, everything cannot be universal as far as the scenario is concerned. Every scenario is different, every part has different actually infections. For example, giving routine iron supplement is not seen actually in some of the Western countries. But we know that there is a more requirement, and the same way the vaccine is all about. What we are practicing at present, what I am practicing in my clinic, is giving the 2 doses of TT at least 28 days apart, commencing from the 2nd trimester. And we give the Tdap vaccine, which can be considered instead of 2nd dose of TT that we give normally at around 24 to 26 weeks. It should be administered during pregnancy in order to provide optimal protection to the baby during its first few months of life. That is, strength of recommendation is A, because it has been proved by many actually studies. Same is with the influenza. As I told you, influenza or any actually the infection which affects the mother is always a question mark. I remember very recently when I was out of station, a section was run at my clinic on Sunday. And on Wednesday, I got a call at 4 o'clock saying that nurse said that the patient is having some sort of discomfort. Her everything is okay, but the saturation is appearing like a 88 or 86. Something clicked to my mind. Immediately we rushed to the hospital to see what actually all about. Patient was very well educated. So she said, no sir, I am comfortable, but I don't know, some discomfort I am feeling, and that's why actually I thought I will call you. A little sweating also I am getting. Somehow I thought whether I'm dealing with the case of pulmonary embolism, because something, the saturation was bothering me. Immediately we shifted the patient to the ICU. And I thought I will immediately tell my intensivist that it could be the embolization as well. But by the time investigations come, we started with the management as well. Now, eventual picture was very, very, very funny. That the patient started, very well settled just by giving the good oxygen. Her otherwise everything was okay. All laboratory was normal. She was eating, she was passing stool, urine was well passed, and she was absolutely comfortable. But when we used to remove the oxygen, the saturation used to drop to 88. And then we thought we need to give her oxygen. So we thought it will settle down in a day or two. We did the CT chest also. We could not find any signs of embolism. So they found some sort of changes of pneumonitis. And that pneumonitis also then started with giving the good antibiotics. But her oxygen requirements never came down. It went almost for a week. Then after second week or so, she was requiring the oxygen to maintain her saturation. We were worried because otherwise all parameters were normal. The patient was from Bengaluru. Naturally, the relatives started saying that whether we should shift her. The intensivists were very clear about it. They said no, because right now we are appearing that she's having pneumonitis. We need to take care of that. Eventually, in the third week, she even needed the NIV for 2 days. And after that, she slowly started recovering. The patient gave review on the Google saying that, doctor, I read all about pulmonary embolism, and I remember that sometimes I have read that patient can get the death as well. And probably if you do not come at 4 o'clock in the morning at this age, probably I would have lost my life. I said, no, but what you have got is not the embolism, probably some brother or sister of COVID, because that pneumonitis was very unusual, which we found. Eventually, patient went very happily to home, but that gave me a lesson that every infection we should take careful as well when it comes in front of us. Same is the story with the influenza vaccine. That's why we recommend in the 9 month to all our patients. That is 26 onwards you can give that. And in case of pandemic, the influenza vaccine can be given earlier as well to protect the mother from getting the infection. The Tdap vaccination during pregnancy to prevent the neonatal pertussis, the key facts are the whooping cough. That also I am not seeing actually at all in last so many days, but if at all it happens, it can give rise to a lot of morbidity and mortality to the baby as well. It is highly contagious respiratory infection. The airborne droplets or direct contact with the nasopharyngeal discharges from an infected person can cause infection. In an immune population, one primary case of pertussis can cause 12 to 17 new cases. It affects people of all ages, not necessarily the baby as well. And that's why it gives a protection not only to that particular mother, but also to the infant for first 2 months of the life. And the vaccination for the neonatal protection should ideally occur between 30 to 32 weeks to maximum placental antibody transfer. So what we are doing in my practice, I will tell you, once the patient finishes her 8th month, we give the influenza vaccine. We tell them that this is basically our concept which we are thinking about. More than 90% of the infant under 2 months of age with pertussis require hospitalization. These are some of the analytic studies they were done to find out the pertussis in the young infants, and 75% of pertussis-related deaths occur in infants under 2 months of age. The complication rate is pneumonia in 15 to 25, seizures 2 to 4, and encephalopathy in 0.5 to 1%. The mothers are the most common source of pertussis infection for the newborn, and the maternal immunization is the most effective strategy in protecting young infants from the pertussis. The literature also says about it, because this study was done to find out at various places, as you can see here, to find out the evidence or the prevalence of this particular infection in the babies. And what they found was very interesting. They have taken into consideration all those viruses which are there, and they found that yes, there are many actually patients who may have this particular infections as well, and that's why we need to give protection to that infection when we can have the availability of that particular vaccine. 52% of the pregnant individuals received a cellular pertussis vaccine, and vaccine was associated with 66% overall disease in neonatal pertussis infection among less than 2 months of infants. Why I'm saying the mother as a major source, again we'll have to definitely think about it. Another very interesting story, a patient who delivered with us by C-section went home happily. After 8 days, I get a call saying that she got a mild fever. Patient was a superintendent of one of the medical college, the patient's husband. So we said, fine, we'll see you and then we'll decide what to be done. We saw the blood picture was again very normal, not very much leukocytosis. So we started slightly escalating her antibiotic, and ultrasound we found a small pocket of 3 centimeters. So we thought we'll wait, we may put a needle, but we want to wait for a couple of days. But in couple of days, again, that pocket slightly increased. So we thought, yes, there must be some infected hematoma or something. So immediately we decided to do the exploration, and we found there was an infected pocket. And then we immediately send the sample for the culture sensitivity. But you know that always the onus then comes to the treating person as well. But to my surprise, the microbiologist called me saying that it is methicillin resistant Staphylococcus aureus infection. Now you can very well think about it. It could be from the various sources, from the even nasopharyngeal mucosa of the patient herself, or many of the relatives who often visit nowadays. That's why nowadays, if there's too much crowd to attend the parturientum, I always tell my patients that don't do that. But they don't listen because they say, no, we want to celebrate because it is a celebration nowadays. But then sometimes this Kannada people teach me very good lessons. They say, यार कालील देव बरते हेळदू बरुद्दुल्ला. म्हणजे कुणाच्या पायाने भूत येईल सांगता येत नाही. म्हटलं भूत नसायचं, पण इन्फेक्शन होऊ नये म्हणून खरं पूर्वीच्या लोकांनी सांगितलेलं होतं, ते आपण ऐकलं पाहिजे. That's how it works. But that patient gave me a good lesson, saying that yes, it's very true that whenever it happens, not necessarily the onus should be on us only, because at the same time there were so many deliveries happened, none of them they got the infection as well. So, but that patient was quite unhappy after that, but somehow we could able to counsel. So, Boostrix has shown the high effectiveness in preventing pertussis disease in infant less than 3 months of age, and this is all these countries who have conducted this systematic study which say all about. So more than 90% of infants under 2 months of age with pertussis require hospitalization. It related rates to pertussis under 2 months of age are documented. The mothers are most common source of pertussis infection, and the Boostrix has shown high effective in preventing pertussis disease in the infant less than 3 months of age. Now coming to the last quick slides of the influenza, yes. There's global and again national expert health authorities who recommend this maternal immunization. Influenza vaccines are recommended during pregnancy since many years, and all these various groups who keep on working on this particular strategy of giving this particular vaccination as well. The WHO, the ACOG, the FOXC, all of they always come out with certain guidelines. It is recommended in all pregnant women from 26 weeks onwards. In case of pandemic, the influenza vaccine can be given earlier as well to protect the mother. And that one need to definitely understand all about. Now, what is the importance of influenza? Because in pregnant women, the fetus having more actually the chance of getting this particular infection, and same is with the newborn as well. And that's why when it becomes a case actually in front of us, we'll have to deal it very, very effectively, because we don't want to have any maternal mortality, we don't want to have any fetal loss, we don't want to have the premature delivery as well. And of course, we never want to shift our babies to the NICU or the NICU. The complications including renal failure, mechanical ventilation could be the extremes of it, not necessarily in every patient, but we really don't know, but there are studies which have said about it. Influenza in pregnancies associated with adverse outcomes like ICU admissions and associated all complications, and even rarely the mortality as well. So that's why giving a good protection is always better. There are certain perinatal outcomes we need to understand. Suppose we treat them with the various antiviral drugs as well, and it has been found that that is sometimes required as well. But instead of treating, always prevention is better. Benefits to the mother are there is a robust immune response which develops. There is prevention of the influenza complication. That means suppose the patient gets influenza, the complications, the morbidity will be comparatively less, the need for the hospitalization can come down, and all those adverse outcomes of pregnancy and neonatal outcomes are reduced. Even the baby gets actually definitely benefit out of it, especially for those preterm and the low birth weight babies. The transplacental transfer of antibody is another boon which the baby gets, and it fills the gaps that all infant immunization will start at 1.5 months as well. So these are some of the literature facts, the studies, which I'm going to just quickly, skip, because I know that you must have been gone through these particular studies in the literature. There are a lot of safety concerns about this particular vaccines as well, and there is now sufficient literature proof available, which says that there is no increased risk of untoward maternal or fetal outcome reported with giving this vaccination. Excellent robust safety profile of the multiple inactivated influenza vaccines over many decades now gives us a little more confidence as well. So the risk of disease is high in both mother and the newborns. The influenza imposes high burden of the problems related to the mother and baby. It gives benefit to the mother, but also gives a lot of benefit to the newborns as well, and which we definitely should understand. About the safety profile, the whatever events we have noticed were slight, flu-like actually symptoms like headache, pain at the injection site, or the malaise feeling. But suppose we manage them with the paracetamol, it works. There are very rarely some adverse effects as well during pregnancy, which we should report immediately. These are the safety informations which we can get from our corporate friends as well, which I am not going to read or tell to you, because they are quite active in our city, and where they definitely come to visit you to tell about all the safety profiles. But best part would be, as I told you, what I do is very important, that you should get the monogram of any particular thing which comes in front of you, because that is what essential is all about. So friends, again, finally, before leaving this stage, my humble request to all of you that, see, this is very important travel for me and for our society, for our city as well. So I need your very good support from all of you. As I told you last time, please start preparing your own broadcast to see that when the voting starts, which is starting in just 1.5 months now, and then we need to see that we'll have to catch each and every actually the known friend or relative of ours to make that number to be reached to that particular place, because I know that all contestants are definitely good people to contest, but finally number matters. So number we need to be properly attained to get that particular thing. Thank you very much once again for the patient listening, and always remain for your all support, the blessings and the wishes throughout my this travel, which I could reach up to this level. Thank you very much.
Thank you so much, sir, for very thought-provoking lecture. And thank you so much for taking time from your busy schedule. Yes. I request Dr. Sujata ma'am to felicitate Dr. Milind Shah sir.
Only because I need to rush, that's why, but I always want to listen, but I will be here for some more time, and then I need to rush for my next travel to the Chennai. Yeah,
Yes.
Thank you.
Now I request Dr. Monica Umbardhan ma'am to have a talk on primary amenorrhea. She is a very renowned, bold, determined gynecologist at Mangalya Nursing Home and Atharva Fertility Center. We welcome you, ma'am, and over to you.
A very good evening to one and all. Thank you, Sujata Madam and Ketki, for giving me this opportunity to speak on a very important topic of primary amenorrhea. I have been specifically told not to cover the management part of it, but only the diagnosis and the approach, so that we have an esteemed expert who will be talking about the management part of it. So what do we mean by primary amenorrhea? It is absence of menarche by the age of 15 years or within 3 years of thelarche in the presence of normal growth and other secondary sexual characters. Usually affects 3 to 4% of the reproductive age females globally, but it varies in different geographies and according to the demography. Beyond fertility concerns, primary amenorrhea can signal an underlying hormonal or anatomical disorder requiring a timely diagnosis. Now, most of us are aware with the normal physiology, that is the hypothalamo-pituitary and ovarian axis. that there is generally a first negative feedback of the gonadotrophin releasing hormone. As the age advances, this negative loop is slowly converted into a positive loop, and then we have the GnRH hormone from the hypothalamus in a pulsatile manner, controlling the downstream of a hormonal cascade. This will increase and stimulate the pituitary to secrete FSH and LH. In response, this will stimulate the ovaries to secrete gonadal steroids, that is estrogen and progesterone, driving the endometrial changes and the secondary sexual characteristics. Now, what are the factors which affect the onset of puberty? The first and the foremost, single most important factor is the genetic, that is, it is hereditary defined. Maternal age at menarche is a single most predictive factor of the daughter's pubertal onset, with approximately 80% in the same range. Second, we have to consider the nutritional status of the patient, that is, the body composition and the fat percentage is very important. A minimum of 17% of body fat has to be achieved to have an onset of puberty. If the patient is very lean, then the puberty will be delayed. Third important factor is the geographic and ethnic variation. So the average African and American girls have an approximate 8.8 years of age, and the Corsicans approximately 9.7 years. Then we also have environmental factors, that is the socioeconomic status and the other endocrinological disrupting chemicals, exposure to light. This is also important because it is said that blind girls have a little earlier puberty as compared to others who can see. And physical activity has intensive athletic trainings can delay the puberty, particularly in sports emphasizing leanness, and this effect is mediated through energy availability and stress hormone modulation. Now, when are we supposed to investigate, and what are the clinical indicators that we would like to highlight? First, no onset of menses by the age of 15 with normal secondary sexual characteristics. We will investigate that immediately. No menses within the 3 years of breast development, signaling potential hormonal imbalance. Cyclical pain but without bleeding would suggest outflow tract obstruction, and early investigation is warranted with family history of other genetic disorders. Now, when we see the patient as a whole, the physical examination, what are the key elements that we would like to notice in these patients is what is the timeline of the development of thelarche and adrenarche, that is the family history of any delayed puberty if she has, exercise pattern and the intensity what the child is doing, any dietary changes or weight changes that have recently taken place, if she is having any chronic illness and she is on any other medications, what are the stress levels and other psychological factors. So appropriate counseling and an essential physical examination with height, weight, the body mass index calculation, the Tanner staging, external genitalia examination, pelvic examination only if indicated, either there are signs of any androgen excess, and a thyroid examination. So we all know about Tanner staging, that is we have 5 stages of breast development and 5 stages of the pubic hair development, and relating to this we will be staging on the clinical examination and the discordancy. If you see whether if there is any breast development that has occurred and it is in stage 5 but pubic hair has not developed at all, then it would more likely be in favor of androgen insensitivity if you have discordancy in the secondary sexual characters. Now, what are the initial laboratory tests that you would advise? First and foremost, we should always rule out pregnancy as a first step, despite of unlikelihood in cases of primary amenorrhea. Second, we have an hormonal panel, that is FSH, LH, estradiol, TSH, and prolactin, which will help us to distinguish between hypothalamic pituitary from ovarian dysfunction. Then in patients who have signs of androgen excess, then total testosterone or dihydroepiandrosterone to be tested, a complete blood count for other systemic illnesses. Now, what is the importance of height when you are considering a patient with primary amenorrhea? So height gives you a critical diagnostic clue, that is a short stature female with primary amenorrhea would be more likely to be a Turner syndrome or having a growth hormone deficiency or a constitutional delay. So we also should look for other physical features like webbed neck, low hairline, widely spaced nipples in cases, and then these patients should go in for chromosomal analysis. Then what is the body habitus evaluation? It can identify hypothalamic amenorrhea or PCOS. Skin examination could reveal hirsutism, acne, acanthosis nigrans suggestive of hyperandrogenism. Then we also have dysmorphic features like shield chest, cubitus valgus, and multiple nevi suggesting of other genetic syndromes. Now the most common cause is constitutional delay. Second, if you have a normal secondary sexual characters which have been developed, but she is not having menses and she is having a cyclical pain, then we should always think about the outflow tract obstruction, that is the anatomical causes of either imperforate hymen or a transverse vaginal septum or cervical agenesis or complete absence of the uterus, that is in the MRKH. Then we also have gonadal dysgenesis, that is pathophysiology and presentation will be disrupted, where if you have ambiguous genitalia in a baby who is born, then we should differ from labeling the baby as a male or a female. We should also differ the naming ceremony, because the name gives an identity to the sexual characters of the baby. First and foremost, an investigation, a proper ultrasound and karyotyping will tell us what is the gonadal development and what is the karyotype of the baby, and then only we should go ahead with the labeling and other investigations. Now, sir is going to speak more about hirsutism, that is PCOS could be a cause of primary amenorrhea, but it will be more suggestive where you have heterosexual development of the secondary sexual characters. So we have made it into 3 different categories, where there are no secondary sexual characters, whether there are normal secondary sexual characters, and whether there are heterosexual characters. So those which do not have secondary sexual characters would be going in favor of ovarian, premature ovarian failure, Turner syndrome, or streak ovaries, or other chromosomal abnormalities. And if there is abnormal development, like breast is there, but pubic hair is not there, then androgen insensitivity would be more common. If you have both male and female secondary sexual characters, we go in more in favor of PCOS. Hyperprolactinemia is an important factor. Most common pathological cause is microadenomas less than 10 millimeters and may require an MRI for detection. Patient may also be on antipsychotics or antidepressants which elevate the prolactin levels. And per se, primary hypothyroidism also leads to an increase in the prolactin levels. If the patient has primary hypothyroidism only, she will present with a precocious puberty. But if it is associated with hyperprolactinemia, she will have a delayed onset of puberty. Now, there is something called as hypothalamic amenorrhea, which is more because of stress, weight, and exercise-induced effects. This is because the critical body fat percentage which is required for the normal functioning of an HPO axis is approximately 17%. So if there is a lean mass which decreases, the stress levels will increase. There is an increase in the onset of cortisol, and therefore there will be a high intensity GnRH pulsatility, which will give rise to amenorrhea. The other pituitary disorders, apart from adenoma, would be prolactinomas, the empty cella syndrome, Sheehan syndrome, and Cushing's disease. The empty cella would be associated with a flattened pituitary, variable hormonal deficiencies, and the patient is usually asymptomatic. Whereas Sheehan's is most of the times due to a severe postpartum hemorrhage, there is a watershed infarct in the pituitary leading to necrosis. Then there will be panhypopituitarism, fatigue, hypotension, and amenorrhea. Then you have Cushing syndrome, where there is an ACTH secreting adenoma. So this has elevated cortisol level, giving rise to weight gain, striae, hirsutism, and other features of androgen excess. Now, per se, when you have hypothyroidism, the features would be fatigue, weight gain, cold intolerance, bradycardia. In hyper, it would be more of weight loss, anxiety, heat intolerance, and tachycardia. So free T3, T4, TSH, and thyroid antibodies to differentiate between secondary thyroid or whether it is Hashimoto's or autoimmune thyroiditis. Genetic disorders, we have Turner syndrome and other chromosomal abnormalities like 46XY, gonadal dysgenesis or fragile X, or you can have Turner mosaics. This would, when you go in for secondary sexual characters and you do a chromosomal analysis, then we would understand which is the genetic disorder that we are dealing it, and depending upon that, if she has testes, whether in the inguinal region or in the labia minora, then she needs to go in for a gonadectomy and then proper supplementation with HRT. When we advise an imaging like MRI or an ultrasound, the first line imaging for anatomical assessment would be ultrasound. It evaluates the presence of the uterus and the morphology, and also indicates if there is any PCOS or an outflow tract obstruction would be seen as hematocolpus or hematometra. The MRI of the brain could be done if the prolactin level is more than 100, when you are suspecting any craniopharyngioma or empty sella turcica, and it assesses other hypothalamic lesions. The MRI of the pelvis is superior to assess the complex Mullerian anomalies because of better tissue characterization. Now, when you build a flow chart for decision points, what are the points that we consider is first is the history, then we have a proper physical examination and a pregnancy test to rule out, then basic differentiation between whether it's an anatomical cause or a hormonal cause. This will be decided by the laboratory testing. Then we have an imaging study and specialized testing. So this is the flowchart that we are talking about. The first is history and physical examination will have 3 parts, that is asynchronous development, immature secondary sexual characters, or mature sexual characters. In the asynchronous one, where we were talking about breast development is there, but pubic hair or axillary hair is absent, it is more of androgen insensitivity. Second is when you have immature secondary sexual characters, we would advise an FSH and LH for these patients. Depending upon whether it is FSH is higher or lower, we will have other features. If the FSH is high, then we go in for karyotype of these patients, whether the karyotype is normal or abnormal. If it is abnormal, it would be more on 46XY or mosaic or gonadal dysgenesis. If the karyotype is normal, it would be gonadal dysmorphism or premature ovarian failure. In cases with immature secondary sexual characters, if you have a normal FSH, it would be more of pituitary function, and we would advise her CT or MRI or sella turcica imaging. If there are mature secondary sexual characters, but then we think about whether there is a distal genital tract obstruction or a complete Mullerian agenesis. If we have high prolactin levels, we should do a T3, T4, and TSH of this patient. If the TSH is normal, then we have to find out the cause of hyperprolactemia in the form of brain imaging. If the TSH is on the higher side, she's probably hypothyroidism, which has led to increase in prolactin, so we need to treat the primary hypothyroidism first. Now, this is the flowchart where a patient has normal secondary sexual characters. We first rule out pregnancy. If the pregnancy is ruled out, we consider whether it is a primary amenorrhea or a secondary amenorrhea. In cases where it is not a primary amenorrhea, it could be either because of chronic infections, endometritis, or Asherman syndrome. These have to be ruled out. In case if it is a primary, then we do a physical examination of this patient. If the physical examination is normal, then we undertake TSH, prolactin, and FSH. If the physical examination is abnormal, then we think about Mullerian anomalies, androgen insensitivity, or true hermaphrodites. Okay. Then coming onto this side of the flowchart, where the secondary sexual characters are absent, we undertake a physical examination, whether the physical examination is normal or abnormal. If this is abnormal, we do an ultrasound, and the uterus is absent, we think of more of the 5-alpha reductase deficiency or 17-hydroxylase deficiency, or the XYK mosaics. If the FSH level is on the higher side, it is more of Turner's or Y dysgenesis or mosaics of Turner's. If the FSH level is normal, it is the other genetic factors like Kalman syndrome, which would be also associated with anosmia, blindness, and you also have disorders of the low estrogen status before the puberty. If the prolactin levels were normal and the FSH level is higher, then we consider a premature ovarian failure, either due to radiation or chemotherapy or other drugs, or galactosemia, or something called a Savage syndrome, or idiopathic premature ovarian failure. If the FSH is normal, then we do the estrogen levels. If the estrogen is normal, then you have chronic anovulation or PCOS, The other one is ovarian neoplasm or granulosa cell secreting tumor. And the other one is feedback disorders including obesity, Cushing syndrome, and androgen secreting tumors. If the estrogen is low, then we have neurological factors, so we should do a brain imaging. If the brain imaging is normal, you have to rule out other chronic disorders of renal or Addison's disease. If the brain imaging, you have to also see whether there is anorexia, whether there is any other psychiatric illness, stress-induced, or pseudocyesis. If your neuroimaging is abnormal, then we look in for pituitary or hypothalamic factors, Sheehan's, or diabetes vasculitis. Thank you so much for a patient listening. I would now call in Dr. Amruta Sate so that we can, at each step, what would be the questions that we have and how would we manage these patients.
Amenorrhea as a complaint, it is very common, and in adolescents predominantly it is very difficult to label as PCOS because the actual pubertal changes, the hormonal changes and the clinical picture of PCOS at 8 years of gynecological age, that is 8 years after menarche, is actually even normal in the pubertal, peripubertal age. So in the end it becomes a clinical diagnosis, but for the ease of our labeling, the recent International Society guidelines for PCOS by Teed et al. And Pina Vega, they have given that menstrual irregularities is an important criteria to consider it as PCOS. Hence, we have refrained from labeling primary amenorrhea as effect of PCOS. Rather, we have kept irregular menstrual cycling as a compulsory criteria along with the Rotterdam criteria for adults. Thank you.
If the patient has come to you with primary amenorrhea at say around 15 or 16, before you undertake any investigations, would you like to give her a progesterone withdrawal challenge?
Ma'am, for primary amenorrhea, first I will look for the clinical picture like you very clearly said, and that couldn't have put it better myself. First, if the child is showing estrogenic changes, that is Tanner stage 4 onwards, and an ultrasound is showing endometrial thickness is there, then definitely I will give a progesterone challenge to begin with. However, if the child is still in Tanner stage 1 and 2 and is at 14-15 years of age, at that point of time I will first prefer to go for a karyotype, because in 30 to 40% of Turner's syndrome, clear-cut Turners or isochromosome Turners and mosaic Turners, 30 to 40% do enter puberty and then they have pubertal arrest. Even in fact 4% they have menarche also and then secondary amenorrhea. So always if there is no estrogenic changes or partial estrogenic changes and primary amenorrhea, I'll go for karyotyping before progesterone challenge test.
At what endometrial thickness would you think of giving a progesterone challenge test?
So any endometrial thickness of more than 4 mm, because 2 to 3 mm will show that the endometrium is estrogenized and the child has entered puberty. But if it is less than that, then I will not give progesterone challenge first. Then in that case, for bone health mainly, every girl has right of estrogen, right to estrogen hormone from 11 years onwards. So if there is clear-cut features of Turner syndrome and the growth hormone part of it has been dealt with, then by 11 to 12 years of age, I will start with estrogen supplementation and not give a progesterone challenge. But otherwise, if the endometrial thickness is more than 4 mm, then definitely give a trial for progesterone.
After she has menses after the progesterone challenge, would you like to follow her up with a proper cycle regulation hormones, or you would wait for the other?
Ma'am, since we know that there will be irregular menses in the first year post-menarche normally also, so we would ask them to make a menses diary and wait for 45 days every time to see if it is naturally occurring. Otherwise, repeat the progesterone. If, however, we needed to give estrogen also, to start, like we've started as a HRT properly with incremental doses of estrogen and then started progesterone, in that case we will not wait, but we will give it separately rather than giving it in the form of OC pills, because there we give a 7 days gap. So the cumulative effect of 7 days loss of estrogen is a very significant effect on the bone health. So we will prefer to give it separately, and in that case continue.
Does the audience have any other questions?
I was having one patient. She was 7 to 8 years old. Her mother brought up. She was having pubic hairs. 7 to 8 years old. No hairs in armpit. No thelarche, nothing. But she was having only pubic hairs. I asked her for investigations and follow-up, but she was not affording that much. She said that, okay, I will do it further, but I lost follow-up.
Yes,
What it could be?
Ma'am, two possible differentials we could think of here. One, that by 6 years of age, it is known that pubarche will start, that is DHEAS production in the body will start, and the first part of the body to respond to increase in DHEAS is the pubic hair. So although in a maximum amount of population, we won't expect this kind of picture that pubic hair will come first and then thelarche, but by 6 years of age, even before thelarche, DHEAS will increase. So in some women, when the genital pubic perineal region is more sensitive to DHEAS, that is one physiological reason why pubic hair may be seen in a 7 to 8-year-old child without findings of thelarche. A more sinister finding would be a possibility of PAIS in this child, because in PAIS gynecomastia will come but later, and there will be pubic hair increase in size, that is partial androgen insensitivity syndrome. So in such case, if we get a DHEAS level done first and it is increased to a biochemical normal level of adrenarche, then we can wait. If the child doesn't develop any features further on also of thelarche, then we can go for karyotyping just to rule out a possibility of 46XY with the partial androgen insensitivity.
Thank you.
When the gonad should be removed?
Ma'am, that is a very, very difficult question, ma'am, actually. It is not for one individual to answer. Actually, we have a multidisciplinary team consisting of gynecologists, pediatricians, pediatric endocrinologists, pediatric surgeons, and most importantly, a psychologist and psychiatrist. Because we need the evaluation of the child per se, of her gender role identity, of her sexual orientation, or his, whichever he feels. Because many times we have seen children wanting to change their gender eventually. So if the child is nearing 18 years of age, we prefer to take a proper psychological assessment and see what the child wants. And because less than 18 years of age in India, they are not legally allowed to take their decision, then take a psychological assessment of the parents and come to a conclusion in between for what is the best possible thing for the child. Because in Tamil Nadu a few years back, based on the endocrinologist and the doctor's opinion, a gonadectomy was done, but post 21 years of age, the child questioned as to who gave the legal right to the parents. And that is why Tamil Nadu only state level has passed a legal documentation that nobody can do gonadectomy unless the child is crossed 18 years and agrees for it. Although in Maharashtra we don't have it, but that's why we keep a multidisciplinary team and we leave that question for the whole team to come to the hand. Yes, ma'am.
I'm asking because there is one patient who is a small child, 4-year-old, with androgen insensitivity, but her external genitalia is showing some hypertrophy, but it's like a female. Okay, now that genital hyperplasia also can affect the child when she goes to school.
Absolutely, ma'am.
So in that case, if we want to prevent further, the gonads need to be removed. Otherwise, what we were being taught that the gonad should be removed after thelarche is complete, so that
That is absolutely right, ma'am, and that is a topic of debate in all the endocrinological societies because the legislation is not in our favor for this, and of course it is very difficult for the parents to comprehend to raise a child with a clitoromegaly as a girl or a boy till they become old enough to decide. It is very difficult, but because we have a lot of medico-legal issues nowadays, so
Okay, can we have any test by which we can know whether that it's a partial androgen insensitivity?
ma'am, the best test and now which is quite easily available at only 8,000 rupees is whole exome sequencing, NGS, next
That will
generation.
give us.
Yes, ma'am. And since PAIS is the most common DSD that we know and it is genetically proven, we almost always get it on the NGS report that there is PAIS. Plus, the problem with PAIS is they will develop gynecomastia, and if the clitoromegaly is not big enough and the child is yet in the age where we can rear in either way, we can tell the parents the pros of rearing as female are better than the pros of rearing as male. So that we can always do, ma'am. And for PAIS, one more thing I wanted to say, I forgot actually. Ma'am, the androgenic effect of on the brain in utero. The effect of androgens on the brain is something we cannot assess. That is the main problem why we don't have a 100% test in DSD which can tell whether to rear as male or whether to rear as female. Because how much androgen was there at what point of time in utero and what effect it has had on the fetus, it only manifests as gender dysphoria later.
The question is because suppose they want to rear up this child as a female, those gonads should be preserved, then only she will have thelarchy.
Yes, ma'am.
But that clitoromegaly which is showing is causing apprehension in the case it has left the secondary at puberty she might have a contradictory
Yes, ma'am.
changes of puberty.
Yes, ma'am. Some studies have been done, ma'am, in Finland, retrospective studies where they took a questionnaire, psychological questionnaire of at least 50 DSD children, male and reared as male and female, of which some of them they changed their gender eventually. Based on that, it was only tentatively said that children with PAIS have a less tendency towards change of gender later. So if the parents are hell-bent and if there is no legislation in that state per se, we can go for gonadectomy early and then give hormonal replacement and rear as female. The odds are less that they would want to change to male gender later, but we cannot say that 100% no. But in 5-alpha reductase, 17-beta HSD deficiency, more likely that they will want to go for a male gender at puberty.
Us for primary amenorrhea, right?
Yes, ma'am.
So for gynecologist, what advice you will give that what we should do at our level at the prima facie?
Ma'am, like Monica ma'am said, that we will see the clinical findings. If the Tanner staging has also pre-pubertal or early pubertal and the chronological age is exceeding the possible age of menarche, in that case we are expecting a more sinister cause, not just CDGP, and more likely CDGP is more common in boys because in girls we don't usually tend to compare about breast stages in girls. So the point where the girl starts getting distressed by it and presenting are usually the girls who have a sinister cause. So CDGP gets masked in girls, not so much in boys. So when girls who like CDGP present, even they need to get investigated, and the ones who present absolutely without even thelarche post 12 years of age, then definitely they need to get invested for possible chromosomal causes, or if they are tall, then hypogonadotropic hypogonadism, which actually is reversible many times, and that is why it even runs in families, ma'am. So both boys and girls, they have a tendency to take after the maternal pattern of pubertal development. So always we can ask for history when the mother had her menarche. If she has also had it by 15, 16 and this child has come to us at 14, she's entered puberty, we might expect that she will also get it later.
Not only mother, but her aunt, paternal side
Yes.
also. The आत्याची कशी आली होती? नुसतं not only the mother,
Yes, ma'am.
but the paternal आत्या, if from that side also can be a delayed menarche.
Yes, ma'am. Actually, ma'am, genetic points we have found out, like kispeptin-1 and CDNK1 gene. So they are mainly responsible for the inheritance patterns of primary amenorrhea and hypohypos in girls. Thank you, ma'am.
There is lot of things to be learned from you actually, Amrita.
Thank
We
you,
will
ma'am.
keep you in lecture of yours. Yes, thank you. Thank you.
Thank you, ma'am. Thank you so much.
Thank you so much, ma'am, for a very thought-provoking and thorough lecture. We will shortly listen about her qualification in short introduction. Dr. Amruta Sathe, madam, she is a consultant pediatric endocrinologist at Dr. Sathe's Tiny Glands Kids Hormone Clinic. She is a MBBS, MD and fellow in pediatric endocrinology, first rank in fellowship. She is attached to Ashwini Sahakari Rugnalaya and Span Hospital. She has presented many papers at national and international conferences. We welcome you, ma'am, and thank you very much. Now we move on to our next lecture on hirsutism by Dr. Rajiv Dabde sir, a very respected teacher, gynecologist, consultant at Krishnamai Nursing Home and Navjivan Fertility Center, consultant at Ashwini Kumbhari and Ashwini Sahakari Rugnalaya. We welcome you, sir, and over to you.
Good evening, everybody. My slides will not have any colors because that's how I have been brought up right from 1988 under guidance of my guide, teacher, and preacher. When I was first time in my life presenting a paper at the state conference which was held in Solapur. So since then, the slides are the same. It's the most important disclaimer that I have to make, that I am neither cosmetologist. Sachin, please come forward. You can sit by the side of Dr. Bahubali Doshi. Please come, please come. Okay. Neither endocrinologist. And the first slide that was presented by Dr. Milind Shah regarding GSK's disclaimer, I like most is they are not responsible for choosing the speakers. Okay. And then it was announced in the group that everybody has to wear green colored shirt. Okay. Then I remember an incident when it was just not an incident actually, just a joke that came in the Reader's Digest, that a Sardarji was supposed to go and attend the conference, and then the dress code was black tie. Okay. So his wife went to the market, purchased the black tie, gave it to him. And then wife had gone for her own work, and then the guy went for his conference, came back, and then the wife asked, how was the tie? Everybody must have appreciated your tie. Yeah, but others were wearing shirts and trousers too. As far as this topic of hirsutism is concerned, it created a similar picture when I was a postgraduate student. Now they call it a modern art, and then you have to interpret according to your own psyche and knowledge. But hirsutism was something like this. At least I never understood that. And then I felt like throwing away the books in this way. But then we were, after our teachers, and we requested madam that this intersex is a subject we are not able to understand. And then she presented that subject in this way to us, made the entire picture clear. And then I thought, yes, reading the books would be more interesting if we have the concepts clear in our minds. I am thankful to the society for inviting these two specialists, and I am more happy because you can have any number of questions on hirsutism. The endocrinologist and the cosmetologist is there to answer these questions. Coming back to the topic, this is excessive male pattern growth of the hairs, and it affects the androgen-dependent areas like mustache, beard, pubic hairs, buttocks, and thighs. It requires 5-alpha reductase to convert testosterone to dihydrotestosterone, and then only it would act at the periphery. Presence of hirsutism exerts significant emotional stress and mental anguish. Hirsutism is hyperandrogenic state. Excess of that hyperandrogenicity would lead to virilization. So, we have to understand what is hirsutism, what is virilization, and there is third entity, what is called as hypertrichosis. Hirsutism is androgen-dependent growth of the hairs. Virilization is signs of masculinization. In a woman, when there is hoarseness of voice, the baldness, the breast atrophy, then we call that the woman is virilized. And hypertrichosis is, this is not dependent on androgens. The children, when they are on anti-epileptic therapy, they can grow hairs all over the body. So the pictures would be something like that. Okay. To understand hirsutism, let's go to the just few slides on the biology of hair growth. These hair follicles develop at 8 to 10 weeks of intrauterine life, and then the pilosebaceous unit develops. This pilosebaceous unit contains hair follicles, sebaceous glands, and arrector pili muscles. It is this muscle which makes their hair to stand when we have fear and cold. Color is of course determined by melanocytes. The total number of the follicles developing is, they develop by 22 weeks of intrauterine life and not thereafter. And the number of hair follicles are same in men as well as women, so there is no gender discrepancy. This hair, when it grows, it undergoes different stages of growth. So one is anaphase, the second is catagen phase, third is telogen phase, and then there is an exogenous phase when the hair is shed. In this, the anagen phase is the longest one. I mean, it lasts for around 2 to 6 years. Then comes the catagen phase and the telogen phase is just a phase just before the hair is shed. Now coming to scalp hair, because most women are bothered about their scalp hair or the hair loss sometimes that occurs. See, this scalp hair grows in an asynchronous manner. It's a mosaic pattern. Whatever the growth pattern we have seen in the hair, so at some places it starts growing, at some places it's in resting phase, and at some places it sheds. So that mosaic pattern is present on the scalp. But when the larger percentage of this pattern becomes synchronous, a larger percentage of them would be growing at a time, and larger percentage of them would also be shedding at a time. So telogen phase is also precipitated by pregnancy, oral contraceptives, febrile illnesses, and even psychological stress. Hair loss can also be seen in conditions like deficiency of micronutrients, iron, biotin, and folate and B12. So this is the one which bothers. And then the simplest solution that we have is we purchase the best of the oils which can make that hair growth. What I mean to say, as a gynecologist, we have to understand that it is not the oils. Okay. And then the oils, when applied for 6 months, at the end of 6 months, all synchronicity always develops and all hairs start growing. Credit is given to this marketing skill. Then why at all do we apply oil or get the hair massage done? This oil strengthens the hairs. It doesn't affect the life of the hair. One more small, not related to hirsutism, but then I was just watching a podcast by this Sania Malhotra, and in that she mentioned that one thing I learned when I became an actress, okay, that I should not be combing my hairs. Because those with curly hairs, if they comb their hairs more frequently, there is more hair loss. This is, hirsutism is an effect of hyperandrogenism. Let's see what androgens do come in the woman's body. They are DHEAS, DHEA, androstenedione, testosterone, and DHT. That's dihydrotestosterone. They are in the decreasing order of serum concentrations that are shown on this slide. The sources of androgens are DHEAS comes only from the adrenals. DHEA, adrenals contribute 50%, 25% by the ovaries and the 25% by the adipose tissue. Androstenedione, adrenals and ovaries 50% each. Testosterone comes from the adrenals, ovaries, adipose tissue. Amongst all these androgens, DHEAS, DHEA, and androstenedione are pre-hormones. They need to be converted to testosterone to exert androgenic effect. And dihydrotestosterone is conversion of testosterone to dihydrotestosterone by 5-alpha reductase enzyme for its peripheral action. So the causes of this hyperandrogenism, ultimately leading to hirsutism, are patients with polycystic ovarian syndrome, rarely ovarian tumors or adrenal tumors, and Hair-An syndrome. That's what, as a gynecologist, we should be knowing what this Hair-An syndrome is. Is ovarian hypertrichosis. HA stands for hyperandrogenism, IR stands for insulin resistance, AN for acanthosis nigricans. This is Hair-An syndrome, is extreme of PCOS. The sex hormone binding globulin production falls due to insulin resistance, so more free testosterone is available for its androgenic action. Patients with hyperprolactinemia also have hirsutism because adrenals have prolactin receptors, and hyperprolactic patients have increased adrenal androgens. Idiopathic hirsutism, I'll come to that. 4% of the patients will have hirsutism in spite of normal androgen levels. And then sometimes during pregnancy, because of pregnancy luteuma, patients develop hirsutism because it releases a lot of testosterone. But only 1/3 of the patients with this luteuma will present hirsutism because a lot of sex hormone binding globulin also comes during pregnancy because of the a lot of estrogen levels being produced by the placenta. So not all the patients will present. And then theca lutein cyst, which we see in patients with molar pregnancy. CAH recognized at birth and during early infancy. There is adrenal 21 hydroxylase deficiency leading to excess production of 17-OHP, which is a precursor for androgen synthesis. So this entity is recognized at birth or during early infancy. Then there is something what is called non-classical CAH, which is little late onset, which presents at puberty, which sometimes can be misdiagnosed as a PCOS. Postmenopausal ovaries are a rich source of androgens because of high gonadotropin levels during menopausal state. They stimulate the ovarian theca cells, and there is ovarian steroidogenesis, ovarian androgenesis. So when a patient of hirsutism comes to us, right from the history we can probably try to correlate what could be the cause of that hirsutism. If the patient has irregular cycles right from the menarche, she is probably a case of PCOS. If the patient has PCOS with early onset of hirsutism, means the irregularity of the cycles is because of, again, hyperandrogenic state, it could be a non-classical CH. Late onset hirsutism with rapid progression, if it is there, then we must suspect either it's adrenal or ovarian tumors coming into play. When the onset is in childhood, it is CAH. And if the drugs like danazol, minoxidil, phenytoin, as I told you, hypertrichosis can be because of these anti-epileptic drugs. When suddenly patient starts complaining that she has increased libido, think of androgen secreting tumor coming either from the adrenal or ovary, because we have to understand that it is the testosterone, it is the androgens which are responsible for this libido. Clinical examination, I just put this slide, Ferriman-Galway score, most unreliable one. Okay. For two reasons. One is because patient may come to us after shaving or depilation, which may be difficult. Plus, this Fermin-Galway score is better assessed in fair-looking girls, not the dark-skinned people. Okay. So, Sachin, in our exams, if we utter this word, Fermin-Galway, naam hi kafi hai, then the examiner will be very happy. I don't know, you can screw your students asking what are those 9 sites, where would be looking, and what should be the scores. Anyway, but that's to complete my lecture on clinical examination of the patient. Continuing the physical examination, if the patient has acne, acanthosis nigricans, frontal or temporal balding, we must think that this is a hyperandrogenism, effect of hyperandrogenism. And thin skin, easy bruising is seen in patients with CH. Now, we want to investigate and treat. So, laboratory investigations for mild hirsutism, no laboratory investigation is required. Just get serum prolactin and serum TSH done, because hyperthyroidism and hyperprolactinemia both would lead to hyperandrogenism. For moderate to severe hirsutism, investigations are necessary to rule out ovarian and adrenal tumors. In patients with regular cycles, it is usually idiopathic. I told you that. Because it is because of very sensitive pilosebaceal units or increased 5-alpha reductase activity, which converts this testosterone to DHT. So, no tests are required if the patient has really regular cycles with hirsutism. If at all we want to investigate, we get the serum testosterone assay. DHA gets metabolized quickly, so not done as a routine, but DHAS, because it has a longer half-life, we do investigate, and it indicates adrenal function because 100% of it comes from the adrenals. 17 OHP assay is also done. Now, as far as testosterone level is concerned, some laboratories would give you free testosterone and total testosterone. Whether we should be ordering free testosterone or total testosterone. The testosterone in the blood is, total testosterone is free testosterone plus the testosterone that is bound to the binding protein, that is sex hormone binding globulin, is total testosterone. But it is only free testosterone that exerts the androgenic action. So, we should be actually concentrating on knowing what is free testosterone. So, it would be prudent to measure free testosterone rather than total testosterone. And the time of collecting the sample for testosterone is 8 to 10 a.m. in the morning hours, because that's the time endocrinologically maximum testosterone is being released in the body. But free testosterone measurement is really costly. The technique itself is complicated because it requires equilibrium dialysis for assay. And it is also unnecessary because presence of hirsutism itself indicates androgen excess. And in hirsute patient, if total testosterone are normal, it is the decreased levels of SHBG that makes the more free testosterone available. Serum testosterone, if more than 150 nanogram, these are really high levels and we should be concerned about the tumors. If serum testosterone is more than 150, we must do TVS to rule out ovarian tumors. And remember, in ovarian tumors, small tumors in the hilar areas can be missed. So if the patient has come for hirsutism and testosterone is high, be more critical in analyzing the ovaries on scan and screen for adrenal tumors. If still no conclusion is there, then we can think this is probably an hair end syndrome or stromal hypertrichosis, which I said, extreme of PCOS. Now, these patients, I told you, will have insulin resistance. Do the tests for insulin resistance help? Even if the patient is a proved case of insulin resistance, insulin sensitizers do not help improve hirsutism. But we as gynecologists should know whether this particular patient, say PCOS with hirsutism, whether we should be knowing that whether this particular patient has insulin resistance or not. Because bringing down the insulin levels is going to help that patient endocrinologically. I forget about hirsutism part. Okay, for her ovarian function. Because hyperinsulinemia makes these ovaries more sensitive to normal or even low levels of LH. And they start producing more androgens and there is anovulation in those women. Aim of our treatment of patients with hirsutism is to reduce androgen production, increase the sex hormone binding globulin, block the action of androgens, and then ultimately the cosmetic care. Treat the cause, very easy to say. Pharmacotherapy has an upper hand over cosmetic measures like plucking or using depilatory agents. Since hyperandrogenicity still remains there, so pharmacotherapy is going to take care of hyperandrogenicity and cosmetic therapy is going to take care of what is being presented. And once the pharmacotherapy is started, the improvements are seen only after 6 months of treatment because that's the life cycle of a hair follicle. A surgical treatment indicated if there is a tumor, and ovarectomy may be indicated for severe hyperandrogenism in menopausal or perimenopausal women. Now, different pharmacotherapies are available. The first of choice is estrogen progesterone pills. Then comes insulin sensitizers. As I told you, they don't have any role in hirsutism. And then anti-androgens like spironolactone, drospirenone, cyproterone acetate, flutamide, or finasteride. Estrogen and progesterone pills, why do they have an upper hand? First line of treatment, because estrogen stimulates hepatic production of sex hormone binding globulin. So, less amount of free testosterone is available to act. Progesterone, it inhibits the LH. LH is going to act on the theca cells to produce more androgens. So, if LH is inhibited, less androgen is being secreted by the ovaries. So, estrogen and progesterone combined also decrease the adrenal DHEA secretion. Now, 19 NOR derivatives of progesterone like nivonorgestrel or norethindrone, they inhibit 5-alpha reductase activity, thus reducing levels of DHT, that's the peripheral action these progesterones have. Other progesterone derivatives like cyproterone acetate or drospirenone, they inhibit the androgen signaling at the level of androgen receptors. Now, as a gynecologist, we have to decide whether low-dose estrogen-containing pills can be used in these patients with hirsutism. Now, our aim of using these estrogen progesterone pills, say for example in patients of PCOS, is not regularizing the cycles, but down-regulating her hypothalamo-pituitary-ovarian axis, so that these patients with PCOS, they have inherent hypersecretion of LH, and LH has a ceiling effect on oogenesis. So, our aim is to reduce LH. Then to suppress this LH, minimum of 30 microgram of estradiol is required. So, any tablet containing estrogen less than 30 microgram is not going to effectively reduce the LH levels. So, anything less than 30 may not effectively reduce the LH, though it may improve acne or hirsutism. But why? Because whether it is high or low estrogen, both are going to increase the sex hormone binding globulin. Now, the progesterone component of these pills, which progesterone should be used? Drospirenone is a spironolactone derivative. 3 mg in oral contraceptive pills equals 25 mg of spironolactone, hence superior to other combinations as far as the anti-androgenic activity in the periphery is concerned. Cyproterone acetate is the next best choice. 19 NOR derivatives like 19 NOR testosterone, they are not useful because they have androgenic action and hence they are not useful. In patients in whom these combined pills are contraindicated, we can use medroxyprogesterone 10 to 20 mg orally or injectable 150 mg 3 monthly. These also effectively suppress LH. These combined pills, wait for 6 months, 60 to 100% of them will show the results. That's seen only after 6 months. Coming to androgen receptor antagonist, more effective when used with estrogen progesterone pills rather than standalone treatment, spironolactone in the dose of 50 to 100 mg twice a day, but the adverse effect is diuresis, fatigue, and sometimes abnormal uterine bleeding. Cyproterone acetate is a derivative of 17-OHP, combined in the dose of 2 mg with estrogen. The disadvantage is that it causes fatigue, loss of libido, or mastalgia. Flutamide is a non-steroidal androgen receptor antagonist. 250 to 750 mg daily is as effective as spironolactone. The only problem is costly and it's hepatotoxic. Then finasteride, it inhibits 5-alpha reductase. But inadvertent administration in pregnancy can affect the male external genitalia. So it must be used, if at all, must be used with a very strong and highly effective contraceptives. Insulin sensitivities, as I told you, they help reducing the hyperandrogenism but not hirsutism. And other options now are GnRH agonist. We give depot preparations, totally the pituitary will be suppressed and the ovarian function can be suppressed. So no androgens coming from the ovary. Glucocorticoids, they suppress ACTH. If fluoronidine hydrochloride 13.9% cream, it inhibits ornithine decarboxylase. It's an enzyme in the dermal papilla essential for hair growth. It is not a depilatory cream. Applied twice daily, results are seen in few weeks. But that must be combined with laser for rapid response as compared to laser alone, and best for mild facial hirsutism. A permanent hair removal can be with plucking, waxing or use of depilatory agents, but they do not have long-term results. Electrolysis or laser depilation, they require repeat settings at 6 to 12 months. So to summarize, if we have a patient with hirsutism, early onset, childhood, think of CH, irregular cycles since menarche, think polycystic ovarian syndrome, irregular cycles with early hirsutism, think non-classical CH, regular cycles, then it is idiopathic, as I told you, either the pilosebaceous unit is very sensitive or there is increased 5-alpha reductase activity. Severe hirsutism, more than 150 testosterone, think of ovarian or adrenal tumors, and treatment protocols are either OC pills, anti-androgens, lasers and photoepilation and surgery. And our previous patient, Dr. Magai, also insisted that I should add yoga in this treatment of hirsutism. So I thank the office bearers of society for having trust in me, and I thank you all for your patient hearing. Yeah, I forgot to tell you about yoga. Okay. This yoga, I want you all to know that what yoga should be done, so that you can pass on that information to your patients to be more effective. So can everybody join me? Just raise your left hand. You can get it off the mobile in your left hand, just, yeah. And with the index finger, you touch your palm. Okay. Now you touch your palm with 2 fingers. Okay. Now with 4 fingers. And now rapidly you have to. Thank you very much for that applause. Thank you. Any questions? We have the endocrinologist and the cosmetologist with us. Sir, please come. Please come.
Thank you so much, sir, for thorough and in-depth lecture on the hirsutism. We welcome you, Dr. Sachin Kore, sir.
Basa, please. I just want to ask you how long should the effect of waxing for those vellus hairs would last, and how frequently one should be doing waxing?
Waxing, we don't advise nowadays, sir. It's absolute. Okay. They go to parlor, and we are a dermatologist, not cosmetologist. Nowadays, many quacks, many people are doing these things, buying a laser and putting. So waxing, I never advise.
No, you would not advise, but my question is how frequently a girl or a woman conscious about these vellus hairs should undergo that waxing, and does it have any adverse effect?
No, as you told, sir, it's depend when we wax it when hairs are in anagon phase, it will be useful. So either waxing or doing lasers every 2 to 3 month interval will be the ideal.
I knew only that much about the woman cosmetology, so I put that question.
No, cosmetologist degree does not exist. It's like
No, nowadays a layman would consider cosmetology as a super specialized branch of dermatology.
it's like fooling. Labeling yourself as a cosmetologist like you are fooling.
Kesh King, like Kesh King oil for hair growth. Okay.
Even dentists are doing that hair transplant.
We are actually, as a we are in the gynec forums, we are actually concerned about using this spironolactone or finasteride. So what is your advice? I mean, we'll be referring the cases to you, but still.
No. See, if any female, a lady with hirsutism comes to me, I directly never advise her go for laser hair reduction. Even though we have a laser, it will not be our first. So get her evaluated, and nowadays job is very easy. I referred it to Harshal. Now madam is there. Get your hormonal evaluation done. If there is some abnormality, you treat first that. And even if the hirsutism persists, we can help with the laser. Primary, we have to treat her hormonal imbalance.
Yeah, as I mentioned in one of the slides, that even if they use laser, it needs settings after 6 to 12 months. Every 6 to 12 months, they need that setting.
Because primary etiology or underlying disorder has to be treated first. But still many नहीं हमारी शादी है जल्दी से कुछ करो फोटो शूट करना है ट्रिप पे जाना है पार्टी है then we have our laser expert Dr. Santosh then I send it to him.
Yeah, because I've been seeing in our OPD whenever these young girls come with a lot of acne and all that, and with the same thing now abhi agle mahine shaadi hai, then Dr. Bahubali Doshi would advise them use some tactics but try to postpone it by 6 to 8 months the wedding. Okay. And then he would prescribe that Dian 35. Okay. Have that estrogen progesterone pill have its complete anti-androgenic action, beautify that woman, and then put her on the
And 70% of these female will be obese. So reducing their weight, that is the more important. We go one step forward. Don't go for external appearance. कल तो वो ससुराल वाले तुमको और कोसेंगे कि periods regular नहीं आते. So get your period regularized. Automatically your acne and hairs will go.
So that's what we do. Give them 6 months of OCPs. The periods are regularized, but that's not the treatment.
परत पेशंट म्हणतात सर जोपर्यंत ते गोळ्या खात होते तोपर्यंत माझे हे तो फॉलिकुलाइटिस होतं रेडनेस होतं इरिथिमा येतं यस लेझर इज द बेस्ट 6 to 8 weeks.
Okay, $1 million question I want to ask is how much does it cost actually for laser?
Laser sir, it depends upper lip area काय depend आहे.
Okay.
So roughly की आता 1,500 upper lip and chin. jaw involve झाला परत 2,500-3,000 एक्स्ट्रा. करेक्ट संतोष? हाँ.
Okay, I just didn't want to ask that question, but I always see you well shaved. Is it the laser effect or shaving, regular shaving effect? Because you are in-house, that's why I asked. Madam, do you want to add some points on the endocrinological aspect? Yeah, please. Yeah, please.
Sir, do you have any experience with the efflornate cream?
I don't think it is very useful, but after doing lasers, we can give it.
After doing laser?
Yeah.
Okay.
It won't work on terminal hair. I don't think so.
And sir, if we advise the efflornate cream and also give the hormonal like spironolactone or something at the same time.
It will have add-on effect.
Okay.
Yeah, please.
There is one patient in the OPD we have seen. She's like around 20-24 years old girl, and she has suddenly started. She also gives a history that the hair started appearing suddenly, and there was a profuse amount of hair. It was like a beard. So, in her case, what her hormonal picture would be like, and what you would think of possibilities in her? How would you approach? Receding hairline too. Yes.
Ma'am, the clinical picture is fitting in sudden onset hyperandrogenism, in which case we need to check the DHEAS levels and the total testo levels in the morning before 10 o'clock, because these could highlight a possible tumor growing in that case if it's sudden onset. However, if the child has or the girl has also become obese suddenly because post-COVID, post the work from home thing, then the insulin resistance also can be a cause of that. But it is always better to rule out the tumor causes first, so to get a DHEAS and total testo done. And since if they are affording, they don't have any issue, then along with the total testo, we can send a 17 OHP also to rule out, although less likely that later on suddenly they will develop for a non-classical, but there are some rare forms of CH also which can present later. So in that case, even 17 OHP we can check.
Thank you.
Yes, sir.
Thank you very much. Thanks a lot.
Any more questions from the audience? Now I invite Dr. Amruta ma'am to have next lecture on the universal screening of pediatric hypothyroidism. Over to you, ma'am.
Hello. At the outset, I'd like to thank everybody, all my esteemed seniors, especially Dr. Sujata ma'am, Dr. Ketki ma'am, Dr. Snehal ma'am, and Dr. Lata ma'am, for giving me this opportunity to speak today on the important topic of primary amenorrhea. And while we were at it, I requested ma'am if I could talk, have a small talk on the universal newborn screening for congenital hypothyroidism. It has been our mission for the Indian Society of Pediatric and Adolescent Endocrinology to work for a universal newborn screening for congenital hypothyroidism pan-India. So far, we have not had a wonderful response, but we felt that if we could get support from all the gynecological societies and all our esteemed colleagues, we would have a much better outreach, and the parents have a greater trust on people who have taken care of them for 9 months when they didn't even know what their baby looked like. If they would trust you more than us for the congenital newborn screening. So I will just quickly go ahead. Oh, sorry. So just a small word on the normal thyroid physiology in the fetus. In the first half of pregnancy, throughout pregnancy, by the ICP model of growth, the baby's entire growth is dependent on the thyroid hormone. And in the first half of pregnancy, it is the T4 of the mother which mainly sustains the fetus. So second half of pregnancy onwards, the T4 production switches to the baby's side. So the maternal T4 is what protects the baby. Even if the baby is going to develop congenital hypothyroidism, in utero the baby is protected by the maternal T4. The corollary is also true. If the mother is having autoimmune hypothyroidism or hyperthyroidism, the antibodies which are predominantly IgG will pass via the placenta and they will be detrimental for the baby also. So if the baby is not going to have congenital hypothyroidism also, transiently they may develop hypothyroidism or hypothyroid-like picture if the mother is having autoimmune hypothyroiditis. Postnatally, what happens, that actually is a more tricky picture. So immediately, because TSH is a stress hormone and the delivery is the biggest stress for the baby, so the TSH surges within 30 to 60 minutes after delivery. T4 also is a stress hormone, but it peaks later. And both these peaks are stunted in preterm babies. So that is why the interpretation of the reports, thyroid profile reports, are a little tedious, and which is why we request either the cord blood sample being sent, because that is spared from this TSH surge, or a sample sent after 48 hours of life. But to send after 48 hours of life in a normal delivery, babies are usually discharged by day 3, so the reports don't come back by that time. That is why we have an appeal for cord blood sampling, TSH sent. So what exactly is congenital hypothyroidism? It can be a genetic cause, it can be aplasia, hypoplasia. All of these factors may or may not present after birth. Sometimes because of the transplacental passage of T4, the baby will not have any obvious manifestations at birth. Or if there is absolute thyroid aplasia, in that case we may get florid findings at birth also. Those cases are rarely missed. The ones which present with large anterior fontanelle, large tongue, constipation, they are rarely missed. But unfortunately, they are very, very less percentage. Maximum percentage are the ones which have no obvious manifestations at birth. And this is what happens when they come to us later, when we miss them at birth. In fact, the C picture is a family that I saw myself, twin babies. Luckily, the male child did not have hypothyroidism, but the female baby was not so lucky. They both came to us at 6 months of age. The male baby just accompanied his sister. The sister was brought to us for torticollis. But it was not torticollis. It was severe hypotonia, because of which the baby was not able to lift the neck also, because it was congenital hypothyroidism. This brings us to the most important slide, highlighting why we strive for newborn screening for congenital hypothyroidism. Because not only is it most common cause of mental retardation and developmental delay in babies, it is also the most preventable, 100% preventable, and the treatment is very easy. Just one tablet, which is hardly 150 rupees one bottle of Eltroxin, and maximum in the best labs, standardized labs, 500 rupees for TSH sampling. There is hardly any cost at all and very little infrastructure required. Plus, unfortunately, India is one of the most prevalent countries in the world, where worldwide its prevalence is 1:3,000, but in India it is 1:800. So for us, we really, really need universal screening for CH, and the outcomes are so beautiful and so gratifying that we actually save lives with just one TSH and one tablet of Eltroxin started at the right time. Plus, a single day's delay leads to a 1% decrease in the neurodevelopment, and that is a huge loss later on, especially in today's era of rat race, where every mother is a helicopter mother and she wants to compare her child with her colleagues right from nursery and play school. That one day's IQ delay is also a huge burden on the baby as such. So which sample do we take for newborn screening? Cord blood sample, definitely we can take, because it is not affected by TSH or surge, although that we take that with a pinch of salt, sometimes it may be affected. Postnatal sample at 48 hours of life is the best. If we have difficulty in taking venous sampling in a neonate, we can take it with a heel prick and do it on a dried blood spot test filter paper. Only problem with dried blood spot test is it requires a bit better infrastructure and availability of dried blood filter papers always. So why do we choose the sample which we choose? TSH is the recommended test rather than full thyroid profile or T4. But between the samples, we can go for either cord blood or postnatal based on our center, whichever is preferable for us. If cord blood is preferable, if it is possible, the only difficulty in cord blood is because we have round-o-clock deliveries many times at night, to remember to collect that cord blood sample. That gives an additional burden on our staff. The disadvantage of postnatal sample, like I said, is the availability of dried blood spot test and the technicality in collecting the sample, venous sample of a baby, of a neonate. But if the baby is going to be admitted in an NICU, then definitely we can go for the venous sample postnatal. So when do we test this? Routine screening is at 48 to 72 hours and definitely not later than 5 days after birth. Basically, for us to interpret it better, we avoid day 1 of life. And for high-risk neonates, every neonate, whether preterm, whether low birth weight, very low birth weight, multiple gestation, syndromic baby, non-syndromic baby, even sick neonate, everybody should undergo a thyroid screening at 48 to 72 hours of life. But for the sick babies or high-risk neonates, we advise a second screen at 4 weeks of age or at the time of discharge, when the baby is well enough to be discharged, to overcome the SICU thyroid syndrome or the non-thyroidal illness. But the rule by far is that all newborns should undergo screening for CH without fail. So the ISPE guidelines, I just included this slide to highlight that the TSH cutoff is more than 20. Actually, we are so used to seeing adults with 0.5 to 5 as the normal value of TSH that when we see 6, 7, we are worried, oh my God, is this congenital hypothyroidism? But up to 20, that is acceptable because of the TSH surge. The cutoff is anything beyond 20. So the prognosis with hardly any cost at testing and no need for any very high-end infrastructure, we have a beautiful prognosis when we have early diagnosis and adequate treatment. However, if there is delay in diagnosis or if there is inadequate treatment, then or poor compliance from the parents' side, we have variable degrees of brain damage. And after yesterday's Ahmedabad tragedy, we know that life is not certain. Everything is uncertain. But one thing that is certain is that we all deserve to have a good quality of life. And it's in our hands to give every baby a good quality of life by ensuring that we rule out possibility of hypothyroidism. So from the Indian Society of Pediatric and Adolescent Endocrinology, it is an earnest and sincere appeal to all the obstetric and gynecological societies and our esteemed colleagues to join us in our mission to alleviate this developmental delay and mental retardation by detecting and treating congenital hypothyroidism at its earliest. Currently, we only have 3% babies in India who are getting screened, although we have a prevalence of 1 in 800. But only 3%. But if individual gynecological gynac hospitals and centers, if they strive for 100% coverage in their center, even if we increase it from 3% to 35% just by increasing the screening in Solapur, that is a huge achievement for us. So it's sincere, earnest appeal. If we work together for this cause and we stay united, we may even succeed at acquiring national or governmental universal newborn screening in India. Thank you so much.
Thank you so much, ma'am, for very insightful talk.
Yes, sir. Yes, sir.
On supplement?
Yes, that's a very good question. Actually, when the TSH is high, if at that time we go for ultrasound thyroid and technetium 99 thyroid scan, if we detect lingual thyroid or absent thyroid, hypoplastic thyroid, or even a large thyroid indicative of dishormonogenesis, we can tell the parents that there is a chance, a very good chance, that the child will require lifelong treatment. However, in our setups, it is very difficult to go for thyroid scan. Ultrasound is possible, and many times we start the treatment soon. Within 7 days of treatment only, we can go for these scans. So the best option is we give the treatment till 3 years of age, when the brain development is complete. Once brain development is complete, we can reduce the dose by 20%, see if the TSH is rising to more than 10. If the TSH is rising, we give objective evidence to the parents that your child is going to need lifelong treatment for better growth, best growth in fact. If the TSH is not increasing to more than 10, we even stop it for 1 month and see. Now if the TSH goes beyond 5, 6 or definitely beyond 10, then the parents will not doubt or question us why we are treating for life. They will also agree to treat for life. All the babies. Thank you, ma'am. Yes, ma'am.
So we have made it a protocol only in our hospital that whenever we have a normal delivery or we have a seizure, during the time when the brother puts in the trolley, we have a sterile bottle that is kept. So as soon as the baby is out and we cut the cord, immediately the cord blood is collected in the bottle and it's sent to the lab. And the pediatrician on their rounds, they check that report that is there or no, and they counsel the parents accordingly.
That is
so
beautiful, ma'am. Thank you so much.
This already we are following it. Yeah.
Yes.
Many people are doing it.
Thank you so much. Yes. That is absolutely wonderful, ma'am. We need that. Thank you.
Thank you so much, ma'am. It was a very wonderful session. Now I request Dr. Sujata, ma'am, to please felicitate Dr. Amruta ma'am.
It will depend on the cause of hypothyroidism in the mother. But definitely, even if one sibling has congenital hypothyroidism, the chances of the second baby having is very, very high, ma'am. So in such cases, if the mother is planning, we prefer to undergo to do NGS in this first baby. If the baby is more than 3 years and definitely still on thyroxine, then and screen for that in the chorionic villus sampling for the next baby. If the mother is having autoimmune hypothyroidism where the adult colleagues, endocrinologists have checked for anti-TPO antibodies, then there is a very, very good chance that the baby will also have. Maybe transient, may overcome later, but will definitely have. Ma'am, unfortunately, there is no liquid or pediatric preparation. We start with a 12.5 minimum dose available is 12.5 micrograms L-troxin. So what we tell them, and very important to convince them, is that you crush that tablet and only put it in 1 teaspoon of EBM, not the entire bottle or anything, because invariably it sediments down and it doesn't go. So just in that 1 teaspoon, mostly everybody knows that or is already aware that isko khane ke sath nahi dena hai. Then they'll be like, how are you giving it with milk? So we tell 1 teaspoon of milk is enough. Just put it in on the baby's tongue. If the baby spits it out, put it back inside, but make sure it goes inside and it is gulped. And only half an hour after that you give the feeding. Yes, sir. Yes, sir. If it is autoimmune in the mother, then definitely, sir, their baby will have. If transient, maybe they'll have, but they'll have. There's a very good chance. Even, sir, if mother has Graves' disease, if the mother has anti-TRAB antibodies present, TRAB antibodies in the baby can sometimes block the TPO production also. So it may cause neonatal hyper or it may cause even hypo. So anywhere where mother thyroid is involved, sir, we definitely do check and cord blood for the baby.
Now I request Dr. Sujata ma'am to please felicitate Dr. Dabde sir. Thank you so much, sir. Now I request Dr. Monica ma'am. Now I request Dr. Sujata ma'am to please felicitate Dr. Ketki ma'am. Yes. Now I request Dr. Sujata ma'am to felicitate Dr. Sachin Kore sir. Thank you so much, sir. Also, our educational partner, Mr. Atul Bhobare, Area Manager, please come forward. Thank you. Mr. Sriram Chavan from Farmed Pharma. Also Mr. Srishel from GSK. Okay. Now I request everyone to have delicious dinner. Thank you so much all the seniors speakers for the today's clinical meeting. Thank you.
Baskere. Thank you. Thank you, everybody. Thank you.